thank you everyone for attending today's lecture, which is going to be on excellence in stroke, a no-brainer. I do have some disclosures. The most relevant one is that I'm co-founder and medical director of Brainomics, an imaging software company for automated interpretation of CT scans in stroke. Now, why am I interested in stroke? It all dates back to the year 2004, when we had a young American patient who came to us with a complete paralysis of his right arm and leg. He wasn't able to speak, he wasn't able to move his right side, and he came very, very fast within half an hour, and he got the typical conventional treatment, which is IV clot-busting drugs, where you inject a drug into the vein. I call him patient 0. However, even though he got his drug so fast, there was no success. He still remained paralyzed on his right side. So what happened at the time is that our stroke physician called me and said, "Iris, wasn't there a company here recently with a vacuum cleaner for the brain?" And I said, "Yes, that is correct. But it has not been tried before." "Well, there is no other chance for this patient. Let's give it a shot." And that's what we did. We took the patient into the operating room, and we knew that his brain still looked pristine. There wasn't any damage in the brain yet. And what we found when we did an injection into the vessels, we found that there's a complete blockage of his main neck artery. And we took the vacuum cleaner and we brought it up into the brain and we started the suction, as you can see on this video here. And what happened? Within seconds, the vessel was open. And whilst we were still admiring this open vessel and the images, we suddenly realized that the patient was waving at us with his formerly hemiplegic hand. And he was saying, "Have you forgotten about me?" That's, of course, when he got all our attention back. And actually, this patient came to us on a Tuesday. He discharged himself on a Thursday, and he took part in a marathon run on the Saturday. He didn't win, but I was pretty impressed. Another interesting thing is that what we pulled out of the brain was pure fat, not cholesterol, pure fat, which is very unusual. And later on, we found that he had an aberrant duct that led directly into his heart. And we published it in the paper and under the title, "Liposuction in Mind." And since then, I get invitations to write for liposuction papers. Now, there are 15 million strokes a year. But unfortunately, only 1% of patients receive this life-saving treatment, although there is level 1A evidence for this. There are not many things in medicine that have level 1A evidence. And thrombectomy nowadays is the single most effective intervention that we have in the whole field of medicine. Now, my vision is that we will provide a joint stroke service of excellence for the whole of Scotland. And what is important here is time is brain. Now, how can we reduce the time to treatment? Because per 6 minutes delay, there is a 1% lesser chance of a good outcome. Per half an hour delay, on a modified ranking score where 1 is and 2 are in a good condition and 6 is dead, 5 is severely disabled, we already slip by 1 point within the first half hour and by another point in the next half hour. So time is really crucial here. Now, one possibility here is to provide training with high-end simulators. And these have now become a reality in my field. They are not expensive toys anymore. They are real medical devices. And actually, you would not go onto a plane if you did not know that your pilot had practiced a couple of crash landings on a simulator. Why should it be different in medicine? And we are very lucky that here in Dundee, we have a high-end simulator which allows us to train not only operators, but the whole team in the speed and in the procedure of this intervention. Of course, there are many other conferences that we're involved in. One of them is our ICA Stroke Conference, which now happens every last Thursday of the month, which is specifically for everyone who wants to learn more about stroke and about thrombectomy and stenting of the neck arteries. Image interpretation. Is there anything we can do there to speed up the process? If you look at this image here, it is quite difficult, even for the experienced eye, to see where the actual damage is. Only if you look very, very carefully can you suddenly see it. Would artificial intelligence be of help here? Yes, of course. That is why we developed an artificial intelligence software which automatically interprets the CT scans and also shows us where there's a blockage of a vessel. This becomes especially important in all the other hospitals in the vicinity who may not have as much experience with interpretation of complex scans looking at the intracranial anatomy and the neck anatomy. Rehabilitation is another area. What happens if a stroke occurred? Is there anything we can do? We looked at a completely new method here, and that is called using mirror imaging and a mirror box. Conventionally, if you have a stroke, you would be moving your arm that is paretic, your arm that has been affected by the stroke, and the therapist would do passive movements of this arm. Now, can we do something differently? Yes. We thought of putting a mirror into the middle of the hand and you doing exercises with the arm that is functioning whilst looking into the mirror, thus tricking your brain into thinking that it's the affected arm that is doing the movement. And our idea here was to check whether we can see the success by doing high-end imaging in MR scanners of the brain to look at the connections that are forming. And very interestingly, we found that we had many, many more connections that were forming newly in the brain when we were using the other arm, the arm that was working, tricking the brain into thinking it's the other side that's doing the movement. Now, if you look at the stroke pathway, this pathway is always the same for every stroke patient. The patients will be coming via the emergency service. There needs to be a clinical evaluation, and then imaging is essential because it is not possible to differentiate if a stroke is caused by a blockage of the vessel or by a burst vessel with blood inside the brain. So if you then gave the clot-busting drug, of course that would be very harmful to the patient. So it is always necessary to first do a picture and rule out that there's no blood in the brain. And then the next treatment would be our thrombectomy treatment, our pulling the clot out of the brain, followed by the rehabilitation. Now, if you look at this, is there a way where we can speed things up? In our normal service, we have already bypassed going to A&E, something that has been shown to be the most effective in reducing time. So a patient is now pre-alerted and comes directly to the CT scanner where the team meets. But in my previous hospital in the University of the Saarland, Professor Fassbender had already in 2003 a brilliant idea. He thought of combining the first 4 steps of the stroke pathway by building a mobile stroke ambulance. A mobile stroke ambulance is an ambulance that has a CT scanner for brain imaging in itself, inside, in addition to the specialists who can immediately perform the treatment at the site of emergency. And originally, we were given a small grant and we went to the scrap heap. We got an old ambulance from there and we told our engineering students to convert it, and we got an old CT scanner donated to us, and we built for several years to get the first prototype of a mobile stroke ambulance, which was then used in a randomized trial. Randomized means that if you had a stroke, you would be either allocated to a group that is treated by the mobile stroke ambulance, or you would be going the conventional pathway. And what we found here is that 58% of patients could be treated within the golden hour, the hour where treatment is the most important and most likely to be successful, versus only 4% in an optimized stroke hospital pathway where A&E was also avoided. Now that, of course, gave us the chance to get a really new and build a professional mobile stroke unit that has the possibility of having CT angiography for looking at the vessels, and a new imaging feature, CT perfusion, which would automatically say how much brain is still alive, in addition to artificial intelligence software on it, and can thus triage and select patients for the best hospital and treat them at the site of emergency. Now, recently, we introduced this first ambulance into the UK. You can see here pictures of the first mobile stroke unit, which was running in my previous hospital. And this is what it looks like inside. You see, it's quite small, but there's still a lot of space for equipment. And again, of course, the imaging and the monitor. Now, my vision is that we're going to get the first mobile stroke unit here in Scotland and hopefully build our very first ambulance. And I'm going to finish with a short video showing you what the ambulance contains. Thank you very much for your attention. I hope I got you interested in the field of stroke. And if anyone wants to work with us in this field and to further research in stroke, please contact our team. Thank you very much.